Hello, everybody. Welcome to the Autism Consortium of Texas. And it's great to have, we're just noticing how many people are coming from all these different areas. Lots of folks from Texas, but several other states too, and that's super exciting. And we're also very excited to introduce our speaker, Dr. Shin Kim. And she's a professor of psychiatry and associate chair for child and adolescent psychiatry at Dell Medical School here in Austin. She's also division chief of child and adolescent psychiatry at Dell Children's Medical Center and executive director of the Texas Children Mental Health Care Clinical Program. She's internationally recognized and specializes in developmental psychopathology, including autism spectrum disorder. Dr. Kim is originally from Korea, and she obtained her medical degree and completed her psychiatry residency at Yonsei College of Medicine, Seoul. She furthered her training at Yale Child Study Center, completing clinical and research fellowships in child and adolescent psychiatry, alongside an MPH, or Master in Public Health, at Yale School of Public Health. Her career continued in Korea as chair of psychiatry at Hallam University Hospital before earning her PhD in epidemiology at UC Berkeley. At Yale, she advanced her autism, school bullying, and genetic epidemiology research, and later was recruited to UCSF, or UC San Francisco, founding the UCSF Center for the ASD and Neurodevelopmental Disorders, integrating clinical and research efforts. Her research, spanning epidemiology and genetic epidemiology, aims to uncover neurodevelopmental disorders risk mechanisms. She has led extensive large-scale research in Korea, the United States, the Navajo Nation, Japan, and the Republic of Georgia. Dr. Kim is committed to community outreach and service, advocating for psychiatrically challenged children, adolescents, youth, and families. Her scientific and clinical contributions have been acknowledged with numerous awards, notably the Presidential Early Career Award for Scientists and Engineers from President Obama. So with all of that, we're super excited to turn it over to Dr. Kim.
Well, thank you so much, Dr. Magna. That was a very kind introduction. And I'm very, very super excited about being here. And thank you for inviting me to this consortium where my heart is. And I just joined here about 6 months ago, and I'm enjoying every moment of being in Austin and working with this incredible group of people, including Sandy and all other autism researchers here and clinicians. And so I'm happy to be here, and I am going to talk about autism increase and what it means and its implication. So you probably heard this a lot: is autism spectrum disorder increasing? And as the care providers caring for our children, and especially children with multiple neurodevelopmental disorders, you would likely encounter this question often. And although it may seem pretty casual or insignificant, this question carries significant implications for your care, our community, and society at large. For example, the perceived increase of ASD has fueled suspicion and in some cases outright rejection of vaccinations. And it also has led to us to use the unproven or dangerous treatments like chelations or secretin, sometimes resulting in the tragic loss of lives. And additionally, resources have been wasted on lawsuits and research into some implausible causes and treatments. This occurs because both lay and scientific communities often associate the rise of the ASD diagnosis with environmental factors like vaccines or air pollution or even rainfall, believing that these factors contribute to the new cases. So my goal today here is to clarify what the increase of autism diagnosis really means so that we can communicate accurate and clear information to patients, their families, and wider community to empower them to make informed and wide decisions for their children. So for this meeting, I hope that we're going to achieve 3 learning objectives. So we're going to know what prevalence and incidence. Secondly, we will identify the factors that might impact prevalence and incidence estimates. And then thirdly, we understand what is the strength and weakness of clinical and epidemiological samples of the disease, of the individuals with disease conditions. So there are a few ways to measure disease frequency, which is incidence and prevalence. Incidence is the number of persons falling ill during a given period of time in a specific population at risk. Thus, it refers counting the new cases of disease during the study period among people who did not have the disorders of our interest at the beginning of the study period. When the instance is a dynamic estimate of the measure of new cases that develop over a period of time, the prevalence measures existing cases at a particular point in time. So prevalence is calculated as the proportion of individuals in a population at a given point in time. Prevalence is also described as a pool, the disease pool in a population, whereas instance describes the new influx to this pool, and fatality and recovery, it reflects the outflow of the pool. So, for example, if disease is very lethal, so they die quickly or very quickly recovered from disease like cold, the number of these individuals at any point of time is going to be quite low. So the prevalence will be, even though the incidence might be not decreasing or not changing. So the prevalence reflects not only the influx, which means incidence, but also the other factors that's associated with other aspects of disease, like availability of treatment, natural history, or chronicity of the disease. So to illustrate this point, I want to show you the experience of our experience with AIDS. So the number of annual incidents of the AIDS cases in gay men during this mid-1980s have been decreased in the US because of the antiretroviral preventive treatment and from public health prevention strategies for reducing high-risk sexual behaviors. So because it's reducing, you might think that the instance decrease, that you will think the prevalence has been decreased too because the influx decreased. However, during the same time, the prevalence of the AIDS in gay men has greatly increased in the US. And because the highly effective treatment for AIDS have prolonged their lifespan with the people for the people with AIDS or HIV. So this is like even though, as I said to you, that there are other factors that make the disease chronic and prolong the lifespan. Therefore, even though instance input of the disease pool decreased, the whole disease pool itself has been increased. I'm going to make this in a more detailed detailed this cartoon. And let's say that suppose the guest arrives at your house for a visit at the rate of 2 person per day and stay exactly 5 days. So how many people will be in your house after a week? The first day you will have 2 guests and none depart. And then 2 guests in your house on the first day. The second day, 2 more guests arrived. Now we have 4 guests in your house. Third day, 2 more guests arrived. You have 6 guests in your house. Similarly, on the first day, 2 more guests arrived. You have 8 guests in your house at this point. And fifth day, 2 more guests arrived. And now you have 10 guests arrived staying at your house. However, on sixth day, 2 more guests arrived, but the 2 guests arrived on the first day, having been there for 5 days, they left. Again, you have another same 10 guests. Seventh day, 2 more guests arrived, but the 2 guests arrived on the second day left. You still have 10 guests in your house. So this shows the relationship between instance and the prevalence. After 5 days, that your house guest number reaches at a steady state, which is 10 guests in your house, as long as the arrival rate of the guest is 2 person per day, and they stay for 5 days. So the steady state is like prevalence, whereas the 2 guest arrival rate is the instance. The thing that's connecting this instance and prevalence is this duration, the 5 days. So for example, if the instance, the people who are arriving is increased from 2 to 3 days, but staying the 5 days, then your prevalence at a certain days later, that you are gonna have 15 days, 15 guests all the time after 5 days. If the guest arrives at 2 days, 2 guests per day, but only stay one day, then you will have 2 guests all the time because it's 2 by 1. So the prevalence and instance is going to be same. So this is the relationship between prevalence and instance. I want to say that it's not the same thing. It's a 2 different concepts. And okay, I have to say I'm gonna make, hang on a second, slideshow, current. I want to make another example of the house guest sample to talk about how other factors are affecting on prevalence and instance. Now, you all have this guest in your house. And being a good guest host, you're making sure that all of your guests at home is well taken care of. And then you learned that some guests have headache. This headache guests are shown as the red-headed people. So you're giving, Tylenol or whatever you need to do to help them. And it seems like, they have 2 people who are having a headache. But then a day later, your friend, the neurologist comes to you and say, hey, this headache is not just red-headed people. There's a different definition of the headache. So you need to include pink-headed people. So you listen to your, headache expert neurologist, and then you begin to include these pink-headed, cherry pink-headed people in addition to red-headed people. So now your prevalence of the headache has been increased like twice. So, okay, I will take good care of my guests. That's that. But then a couple days later, your friend, neurologist comes in again telling you, hey, did you check your basement? And I say, why? And he's saying to you that, oh, there is a new New England Journal of Medicine article saying that this headache is responding to the exercise, and because this headache is so bad that people are exercising like crazy. And you're saying, no, no, no. But then you give in. So you go down to the basement, and then you find three more people in guests in the basement, the doing more exercise. So okay, your now prevalence of headache in your guest is increased like 25% or 30%. So now it makes you get thinking, okay, if people are doing everything, including exercise, to make their headache get better, what else would they do? They're gonna go to the rooftop and where the good sun is and the areas maybe there are more people. Lo and behold, you found like way more people now, like 45% of your um, guests look like have headache. So, but then your guest in your house heard about it from someone, and then all of a sudden they realize that there is a from the headache was from 13% to 50%. There's something going on in your house and causing this headache epidemic. So this is the other factors that we need to consider in this type of prevalence. Number one, what happened? We expanded our headache definition from red-headed to pink-headed and pinkish-headed. So that's the definition of headache has been broadened, which is corresponding to the diagnostic definition. And then secondly, you're including more people to assess because it's not just the house in your first and second floor. Now you're looking at the basement and the rooftop to include everybody. And number three, you did that for at the beginning by the suggestion of your expert friend, but now that you learned, you're aware about this, and then you do it by yourself and identifying people with headache more. So this is like a public awareness, increased public awareness, and also it's that you are getting better with the case identification. And this is what's happening, other factors happening in the community that when you look at the prevalence or incidence. So now I want to say, before I go to the prevalence of other disorders, our autism disorders, I would just want to, all, but I want to go through the DSM-5 ASD diagnostic criteria. ASD is characterized by severe and pervasive impairment in two domains of development. One is the impairment in the reciprocal social communication. The other one is the presence of restricted and repetitive behaviors and interests and activities. And the disorder occurs in an early childhood, and the level of impairment and consequent service needs of individuals with ASD, while variable, is still quite high for even the least severe cases. The impairment is lifelong, and considerable support is required to navigate routine, social, and educational situations. And I want to say that ASD has been received incredible attention due to the reportedly rapid prevalence of prevalence from 0.01% in 1960s to like 2.6% in 2000 worldwide. And this increase of ASD prevalence was also evident in US, as you can see in this CDC report. And this led some, including the media, suggest that there was an autism epidemic. And this gave rise to a plethora of claims about the environmental causes and treatments. As I explained, that some are even popular, even though the data indicated that was wrong or dangerous. But now we are armed with this knowledge that we talked about, the difference between incidence and prevalence, which will allow us critique prior epidemiological studies of ASD, meaning that what these changes refer to the changes in prevalence or incidence, or also are there any changes in case definition or finding methods over the last 4 decades. So let's look into several examples. So now, this is an example of to show how diagnostic criteria impact on the prevalence of ASD. This is Finnish colleagues, and they estimate the prevalence of ASD in Finland in approximately 40,000 adolescents using different diagnostic criteria. Using Kanner diagnostic criteria, which is the most strict diagnostic criteria, and then ICD-10 DSM-4 autism criteria, and then ICD-10, the most broader diagnostic criteria, they showed that the autism prevalence has been changed 4 times just with the change of the diagnostic criteria in the same population. Now, look at this curve of the ASD in Minnesota. There has been little variations in between 1981 and 1990, but in contrast, after the number of children with ASD rose from 250 here to 4,000 in 2002 and 2001. And during the same period of time, the total number of children who were enrolled in the school special education category rose by 50%, whereas the number of children enrolled in schools only rose by 6%. What happened? What happened is a broader definition of autism has been introduced in this with DSM-3R, ICD-10, DSM-4, but more importantly, in 1989, the Individual with Disability Educational Act was implemented, which means that in the past, these children didn't come to school. Now, with this law in place, that these kids come to the school and then being counted in the special education population. So this type of data cannot be just simply interpreted as the increase of our autism cases. Now, I want to show you the access of the service how this can affect on the prevalence too, especially when prevalence has been estimated using administrative records such as the hospital records or special education records. So when access to the service is limited like this in the left side, and looking at the service data, the prevalence is going to look lower when compared to this community where the service access is higher and the prevalence looks higher. However, when these all black dots indicate the individuals with the autism, and these two populations actually have same prevalence, but capturing the people with autism using service data is going to indicate that there are two very different prevalence because of the access differences in the services in these two different populations. Now, I want to look into one country a little more detail, which is in this case, UK, United Kingdom, over the last 10 years. In this short time, ASD prevalence has been changed from 0.1% here in 1999 to 1.6% here in 2009, 16 times increase in over just 10 years. So how is that possible? There's not a single disease that increased this fast in just a short period of time. So let's examine this UK data very closely. In an early study, like 1999, the number of children with autism was determined by using service data, like I described before, like school, clinic, and insurance data. These researchers did not examine a single patient, even though they look at like 500,000 data. And not surprisingly, the prevalence based on the service data will lower because for variety of reasons, that many children with ASD will be missed out for because like limited access to the services, low quality school assessment or resources or low public awareness. The later studies in this area, four studies have been actually examined the children, but different group of children. So in early 2000, Fonbone and Baird look at the younger age group. And in contrast, Baird and Barron was looking at the 9 to 10-year-old children. And it is not surprised that ASD prevalence in younger age children was 0.6, whereas older was 1.2 and 1.6%. Is because it is a little more accurate and easier to make an ASD diagnosis in older children because the ASD or symptoms vary and changes a lot in younger children. To further illustrate the importance of knowing who was counted in as an autism patient, let's look into this later two studies. The Baird studied ASD prevalence is lower because they included only children at high risk of having developmental disorder. That means the Baird screened and examined only children in this special need population. In contrast, Baron Cohen included both special and mainstream school children, but unfortunately only 25% of the mainstream school children responded. So that was a bit disappointing. And when you include more children, then it is not a rocket science. The prevalence is going to be higher. So now you know that it is, when we closely examine the data, they can tell us that actually prevalence might, it's not clear if prevalence has been increased or changed, or the method have been changed, and the way that we identify children with autism have been changed. And that gave us an impression of increased prevalence. So this means that in order to get valid and reliable prevalence instance measures, we need to have sufficient size of population, and we really need to include all the children at risk for outcome, no matter they are in regular school or special education or homeschooled. And we need a systematic and standardized screening of the population, and also standardized diagnostic assessment. And probably age for reliable and valid case assessment is important. and we need to apply consistent case identification method over the course. So with that, Korean prevalence, we based on this, we discussed, and in order to overcome this prior studies shortcomings, that it seemed like the only way that we can do this, determine true ASD prevalence, was to apply rigorous standard epidemiological method to a general population. I'm sorry, there is a amber alert. I think you guys will have that too. So it seems like the only way that we can have a true and accurate ASD prevalence is to apply rigorous and standard epidemiological method to a total population sample. And so our team planned such a study in Korean population. So why? But so Korean prevalent, why did I do the study in Korea? Well, besides the obvious reason that I'm a Korean and I would love to do something in my country, that there was much more important, actually scientific reason I wanted to do the study, and South Korea made it possible to do the total population approach. So it's designed using total population approach to identify all children in a given study area, irrespective of their prior service use history or diagnosis. So, and it was clear that optimal ASD prevalence studies require comprehensive, valid, and reliable case identification methods in a genetically and culturally and environmentally homogeneous population. And Korea fits that bill perfectly. Korea originated from a relatively ethnically homogeneous ancestral group, and culturally, Korea speaks one language with a literacy rate of almost like 99%. Because virtually all Korean children attend compulsory public schools. And it also means that I could recruit representative unbiased sample through school-based screening in order to achieve comprehensive and thorough identification. We chose metropolitan Seoul area because as our research site, because 1/4 of Koreans live in this area, so we can generalize what we find to the entire Korean population. And we did a multi-phase screening first, and then when they are screened positive, we invited them for the confirmatory diagnosis. And we used multiple informants, not just for the screening, not just the parents or teachers, but both of them. And then for the confirmative diagnosis, we use standardized assessment, including ADAS, ADI, and cognitive testing. And these are the pictures that we took at one of the 33 participating schools. And we screened 23,000 children. And this approach allowed us in the end that we included a clinical population of children with ASD that is previously identified by service systems. They might not have the diagnosis of autism, but whatever reason, they use the service system. In addition, we studied non-clinical population of ASD children who have never been diagnosed or received any services. Screening questionnaire was the Autism Spectrum Screening Questionnaire, a 27-item instrument that measures social interaction, communication problems, and restricted and repetitive behavior, the essential features of ASD. And children whose parents and teachers provided high ASSQ scores, and or those enrolled in the special education or patients, for whatever reason, want to come for ASD diagnosis, they all, and disability registry enrolled kids are all considered to be screen positive. And this is the ASSQ screening questionnaire, and this is the relationship between parent score and the teacher score. The correlation is significant but modest, suggesting the importance of having multi-informant screening. And as I say, the screen positive children were invited for the conformative diagnostic pathology. And then the final best estimate diagnosis was made by independent clinicians using DSM criteria based on the review of data collected from ADAS, ADI, cognitive things, and all other previous data. And in 2011, we reported 2.6% prevalence estimate, much higher than any reported at that time. At the time, the estimate was 1%. But closer examination of our data showed that ASD prevalence in clinical sample here was 2.8%, which is comparable to 0.7 to 1.2% in US and European studies of clinical population at that time. So perhaps more important, one was the 1.8% that if individuals found in this non-clinical population, this means this new increased prevalence in Korean study is this 1.8% of ASD children, not in clinical population, who were previously unrecognized and untreated. And then we got interested if there is any differences in these two different group of ASD population in terms of clinical presentation. And so we found some, and the clinical population, most of the kids were diagnosed with autistic disorder, and the more severe ASD symptoms measured by SRS score, sex ratio was 5:1, mean IQ was 75, with about 60% of kids having some form of moderate to severe ID. And the adaptability score was about the mean of the adaptability score in the typically developing children is 50, and their score was 38, much lower than the typically developing children. In contrast, non-clinical sample, most of them had atypical or the Asperger PDD NOS diagnosis at the time. Now we are all under the ASD spectrum umbrella of the spectrum, and the SRS score was lower than the clinical population, 64, but still much higher than the typically developing children, 50. And the sex ratio was 2.5:1, still male dominant, but the difference was not that was less dramatic. Their mean IQ was 98, with only 16% have borderline intellectual functioning or mild intellectual disability. And their adaptability was 43, better than the clinical sample, but still much lower than the typically developing children. So not surprisingly, children in this in the non-clinical population, group was less impaired. However, when compared to the typically developing children, this non-clinical subjects have relatively poor adaptability and high social responsiveness score, indicating even in the children with ASD in the non-clinical population will have significant functional impairment. We can go that. And then, so there were initial skepticism. That was 2011 about our finding. And to be honest, we were also a bit skeptical, but we carefully checked and rechecked our method and analyzed until we were confident about our report. So because the replication is the sincerest form of flattery in our science, we have been quite gratified to see the similar subsequent reports coming from other projects. 2018 survey, National Survey of Children's Health Report, and the Australian studies, and recently completed studies in South Carolina, and the CDC 2023 MMWR report and study in Japan all have replicated our initial findings. And we are also aware of some other studies like in Georgia in development or underway. Now, it appears that ASD prevalence is stable between 2 to 3%. However, we still do not know about the changes in instance. This is important, even if instance changes are small, as these small changes might point to the mechanism that are increasing ASD susceptibility. Instance changes can be monitored prospectively following children with a consistent and reliable case identification methods. So over the past 10, 12 years, we have now annually screened more than 60,000 children, 7-year-old children every year when they are entering school system. And we're utilizing same consistent case identification method in the same target area in South Korea using, and we have computed instance estimates for the last 10 consecutive birth cohorts using simulations and modeling and machine learning methods. And I am very excited to share, this is my first time to show this instance data with the public for the first time, and I'm very excited to show you this. So this is the preliminary result of cumulative instance of ASD. Cumulative instance meaning that I'm not waiting for the diagnosis happens and then make a diagnosis that are like 2 years, 3 years, but we are waiting till 7 years or 7-year age. That's hence the cumulative, because at that point, diagnosis of ASD is much more stable and accurate, so that we are, this is 7-year cumulative instance of the ASD. And the gray is the total instance and this is the birth cohort, meaning the kids who were born in 1998, 1999, 2000. So we have this about 12 birth cohorts. So the instance seems like up and down a little bit, but pretty similar. It's between 2 to 3%. The reason going up and down is because of the number of sample sizes and also the missing data that we have to impute it. So there are some of these changes, but this latter scores, the lines are much more robust. The cohort assessment with about every year 7,000 to 8,000 children without much of missing data. So it seems like instance is 2 to 3%. The instance is going to be similar to prevalence when there are not a lot of population movement and there are not a lot of other external factors affecting on the case identification method. So the instance seems to be stable between 2 to 3%. And then the blue is the instance in the boys, and the pink is the instance in the girls. I know maybe this is not politically correct to use this color code, but I just love these colors. It's more of my my preference. Pink and blue are the my favorite colors, so I put it in there. Um, and the blue color, the male instance and the female instance just in general moves with the total instance data. And as we expected, then male instance is higher than the female, like we saw in the prevalence data too. So from this data, it seems like not only prevalence, but incidence are pretty stable between 2 to 3%. Now, we've spent about an hour or 15 minutes discussing the rise in autism. Autism prevalence has clearly increased over the last 4 decades due to the factors like broader diagnostic criteria, greater assessment, public awareness, improved case identification method, and better resources for individuals with ASD. And from our preliminary data, that it seems like instance stays in the similar way too. And because, and so I can say I'm going to look into more other factors if I have missed anything that might indicate change in the autism instance. But current preliminary data supports that there is no increase in the instance either. So it is essential that we communicate that the at least prevalence has been clearly proven that there has been increase of the prevalence because of the many factors. And we need to discuss this and communicate with our patient, families, and the community. And hopefully I can make a more clear comment or statement about the instance, that instance has not been increased over the last 10 years too, that, you know, we can communicate this with our families and the society to our communities so that we can help our society to focus on the real issues like protecting our children from the preventable disease like polio and measles rather than fueling vaccine hesitancy or vaccine conspiracy theories. And consistent sharing and dissemination of scientific facts within our community is going to be a key to making this happen. So with this, I now thank you for your attention, and I am open for the question.
Fantastic. Thank you so much, Dr. Kim. That was really enlightening and helps us think a little bit too about our specific regions or areas, you know, like in Texas or the other states that people are coming from as well, and what that means in terms of clinical practice. I want to encourage people to put your questions in the Q&A, and I do see a couple questions there, so go ahead and add more questions if you want to, and we can work through some of those. So one question here is, what's your opinion about pathological demand avoidance, PDA? It's not an accepted diagnosis, but do you think it will be one day? And it is a form of autism, or is it something else?
I think it's part of the symptoms, but rather than, or behavioral manifestation, rather than part of the specific disorder. I see a lot of pathological avoidance of the demands, not only in children with autism, but also in many other kids who have behavioral problems. So it'll be hard for me to think that this will become a specific diagnosis itself, because it's throughout the whole different dimension, and it's and not under one kind of mechanisms um, that I would think it would not be easy to find any biological substrate of doing it. For example, our kids with autism are gonna um, um, do this. We're gonna avoid the demands because they are preoccupied with their special interest and they want to continue to do it, or for some texture or the sensory issues. Whereas other kids, for example, oppositional defiant children, will do the same thing for the different reasons and different gains or different biological mechanisms. So I wouldn't, at least in the near future, I wouldn't expect that becomes a specific diagnostic category, but I think it might be something that's helpful for the clinicians to understand and guide our clinical care for the children.
Thank you. Okay, great. The next question is, it was an interesting approach to explain the relationship between prevalence and incidence. How do you think that CDC has researched the prevalence in the US by checking with 8-year-old child to prevent the cumulative number, but still the prevalence of ASD keeps increasing based on CDC research?
Yeah. So I think CDC research, which I'm very proud to say that Sandy's team is becoming the Texas site, correct, Sandy? Yeah.
Yes, we're one of there's 2 Texas sites now, and we're one of them.
Yeah, we are very, very proud of that, and we are very excited about it. It's a very extensive kind of way to identify children. They still don't see the children, but we look at the all the record, and we don't take it as diagnosis record, and the clinicians make a diagnosis based on the record. So again, as I talked about the way to examine the prevalence and instance using the data, administrative data, that the more we are good at understanding what the autism is, and also have more resources to provide the services. Just thinking about the school, if you don't have resources to provide services, making diagnosis for school diagnosis for the students in their school does not make any sense, because that becomes a problem for everybody. So the more resources you have, the more you're going to actively you know document these things and try to provide the services for kids. And the clinic and also the CDC data not only includes the school data, but also hospital data. And it has been shown if you use both data, your prevalence in that state is higher than the state that uses only one database. So it's again showing that it depends on the resource when you are using documented administrative data and access. So that's why it has been steadily increased, because we are getting better and better. But when I reported this 2.6%, it was I wasn't saying that that is the exact number that's going to be settling in, although it was pretty interesting to see that the CDC number was exactly same, and what they're describing about the male, female, and the cognitive profile, everything was very interesting because it was almost identical. But what I was saying in the paper, and now too, like the graph that I showed you about cumulative instance, there is an error range, and it seems like it's between 2 to 3%. And I often get the question, do you think it's going to go up and up and up? I don't think so. At a certain point, that we have done a very great job identifying our children with autism and neurodevelopmental disorders. That's going to be at saturated, and so what I'm expecting or looking at is going to be it's going to be between 2 to 3%, and I expect the CDC study and all other studies going to be with the range of a margin of error. It's going to be 2 to 3%. It can be 3.5%. That doesn't mean it's a specifically 3.5%, but that's that error range. So I think that's the reason why CDC study has been showing that it's has been increased. And again, I expect that's where by the time that we have done our great job, which is I think we are approaching that, we will be near the 2 to 3%.
Oops. Okay, got my audio back on. Thank you. That was great. Yeah, there's a lot of interesting things about the CDC data because I think the states vary vary in terms of their prevalence rates, although they're probably in that range, right? But it depends on the resources that the state and the communities are contributing to early detection and stuff like that in some cases. So very interesting to look at that.
I agree.
And so Elizabeth asked, in the research, how much of the diagnosis increased due to the broad criteria?
That's a very interesting question. So actually from DSM-4 to DSM-5, people have been worried about getting stricter diagnostic criteria and losing diagnosis. So actually, it was funny that CDC and we did report the paper at the same time, which was, I will show you the data that I skipped. Let's see if I can go. I think we have a little bit of time. Okay. And I will do that. Sharing. Can you see the slide?
Yes.
Yeah, so this is reported in 2014, almost same time. Our study was reported in JCAP, and CDC study was JAMA Psychiatry in 2014. So we wanted to see how ASD prevalence has been changed from DSM-4 to DSM-5, because with the DSM-5, people have been worried that we are losing the diagnosis, so we are going to lose access to the treatment because the diagnostic criteria became changed, and also the subcategory of Asperger PDD-NOS has been all gone. So we did the DSM-4 and DSM-5 diagnostic criteria comparison, and actually we showed exactly same findings. And our study showed that DSM-4 diagnostic criteria, it was 2.6%, DSM-5 was 2.2%, about 17% decrease. And CDC study showed DSM-4, at that time, there was 1%. So DSM-4 was 0.9 to 1.13%, and DSM-5 was going down to 0.7 to 1.0% in 2014. So there is about 18% decrease. And who are the one who losing diagnosis? So this loss of the decrease of diagnosis, the impact was same in our study, male and female, about 16 to 20% of loss, whereas the CDC study didn't have this data. What we had was that most impacted by this DSM-4 and 5 is that the PDD-NOS in our study with high IQ has lost their diagnosis. And the CDC study also showed that those with high IQ have lost the diagnosis in DSM-5. And then CDC study didn't have the newly introduced diagnostic criteria of social communication disorder, but we did have it. So we look at it, and when we look at the kids that who have lost the diagnosis, that who had a DSM-4 PDD diagnosis, but do not have DSM-5 ASD diagnosis anymore, when we look at them, these are the kids mostly with PDD NOS with high IQ, and 77% of these kids met the diagnostic criteria of social communication disorder criteria, meaning that they have social communication problems, challenges, but they did not have RRV criteria meeting. So that's why they lost the diagnostic criteria, but they still met the criteria of ADHD or any other anxiety disorders. So in our study, when we add up with DSM-5 ASD diagnosis and SCD prevalence, it was same with DSM-4 PDD prevalence study. So I hope I answered the question.
Yeah, and kind of building on that question, the next question talked about the controversy of how broad or narrow to make the definition, and then asked whether to subdivide it. How do you think this should go in the future?
Yeah, you know, I think it's gonna be all depend on the data that you want to see actually how these kids who were diagnosed with this spectrum or this ASD spectrum, what's gonna be their trajectory. That some are gonna be do just get better or you know, become the mainstream, or some are gonna have you know, continue to have challenging trajectories. And this is really important question that actually Sandy and I and our autism team here are really putting our heads around together and wanting to do the follow-up of this population to actually answer this important question, because the definition of autism is not just cross-sectional symptom cluster, but we want to know how they move forward together. And actually, this is the same cohort of group of kids who are actually traveling together over the course too. So I think that that's what I believe, or I would love to see, or I think significantly contribute to the understanding of underlying biology of autism. And about the subdividing it, I, I think the definition of autism, there are several reasons or several purposes of the definition. So as a clinician, for all of us, we say autism in a way to describe the kids with social communication challenges and their special interest. So I think, and then also the other big purpose is to let them have the interventions they need. So for that, I think current autism diagnostic criteria is okay, although uh, just today I got an email from my colleague Summer Bishop, who is trying to build some advocacy for around in the intellectual disability population who don't get the same benefit, who need the same intervention. And so but that's a different story. And I think for that reason, that if we understand what it means and we are communicating for that reason, I think current definition of autism is fine. If we want to subdivide it or narrow it or broaden it for the purpose of other reasons, for example, research, there are some group of people who are looking at the autism with, delayed walking or female or a language impairment to understand the underlying biology, and it gives us a better understanding or kind of homogeneous population. As we all know, when you see one patient of autism, you see one patient of autism because everybody is different. So if that helps you to understand the underlying biology, I think that's a way to do it, if as long as we understand what we're doing. But the reason that we kind of combined all those diagnoses into one on the spectrum is based on the data at that time available. There was no differentiation between this different diagnostic group in terms of their outcome. I am not completely assured by that because the data they have are the data from the clinic, that the ones who only come to the hospital, who have access and who are serious enough to come to the hospital. We missed all the children in the community who still have challenges and impairment, however, didn't have any mean or didn't were misunderstood. We don't know what happens to these children. So unless we include all of population, I think is that a right thing to do? I don't know. But at that time, with the data available, that was a decision made as best as the scientists can.
Yeah. Yeah, this is going to be going forward, we're going to be having these conversations for sure and trying to figure this out. But yeah, the general population data, I mean, most of the data, at least we've had in the United States, have been clinical based data, so it limits what we can understand. So there's a question from somebody who works in the ER, and there's not a lot of time to assist patients who are not engaging in treatment. What specific strategies do you recommend that can be helpful to engage patients in the spectrum in medical and mental health treatment in this fast medical environment?
That's a very challenging question. Again, each individual has a different manifestation. But one of the things that our population has a challenge is the changes and the new situation, and without explanation, our kids have a really hard time, and they get very scared and very anxious. So if if I am in emergency room with autism kids, I'm trying to talk with the parents or the guardian first about what the child gets most anxious, what makes them very vulnerable. Is there any good strategies for us to help him get through this fast medical environment? And I will follow their lead. Um, and in general, I am trying to explain if they are ready to listen. And, although, this is emergency room, and if they are in danger, sometimes we just go ahead and then do it, even though the kids scream and panicking, because it depends on, their life depends on it. So then we have to do it. But otherwise, I will try to do this with with the guidance of the parents. When we did the study and we had to do some blood draw, we had to use all sorts of things. So we had the kind of panel that we made to put between the arm so that the kids don't see it. We distract them with the iPad and everything. And we also put the lidocaine so they don't even feel it when the needle goes in. But and sometimes just explaining worked, because it's just not knowing was the most scary thing for them. So we really had to be creative, even with the phlebotomy thing.
Yeah, those are actually really good strategies, I think. Um, yeah, so and just to let folks know, so we will continue answering questions. We have more coming in, which is great, until 1:30. Is that okay with you, Dr. Kim? We'll
Yes.
just go through. And so our next question is, in your research, Did you collect any data on the number of families that opt not utilize therapy options or school services? I found in my recent experience as a parent of an autistic child who embraced early ABA, OT, and speech therapy that a growing number of autistic adults are requesting more neuroaffirming care options or existing traditional systems in search of that. Do you have anything you can share on this?
It's a very tough situation. Um, so the Korean study that I did, there were not many the interventions available. And even that time, even then, still we use play therapy and other things. And I was like, please don't do that. It's play therapy isn't going to work for your child. But there was so scarcity of the treatment, and we had the ABA, but ABA was so rare that parents sometimes have to learn how to do it because no therapists were available. So it was the other way around that we had to do, like, they want to do it, but it's not available. Um, in my practice in the US, I had a very blessing that most of the parents wanted to do the therapy and very advocating for their kids and try to get as much therapy as possible. And I could see that that helped changed our kids so much. There are some ABA. ABA has been quite a challenge because the BCBAs, it's really good ABA therapists are pretty um, not not so frequent. And then there are a lot of turnovers of the therapists. So, as we know that our kids have a hard time to meet new people, and finally they got to know each other a little bit, and then by the time they need to work, and a couple months later, the registered behavior therapist left. So that became such a hard thing to the point that some of the parents has to stop ABA because it was very traumatic. So I was in a situation more of like rather than refusing this treatment, then in a spectrum of want to have the good treatment, have more treatment. Um, I I understand that there are a growing number of autistic um, adults. So it's a whole different area. The making diagnosis of autism in adulthood becomes not an easy thing because you know you can look like autistic at the age of 20 and 30 for a variety of reasons, even though you don't have autism. Like, you have severe anxiety, severe depression, severe ADHD, and, sometimes some psychotic thought disorders look like you have autism. As we all know, that autism diagnosis starts in early childhood, so we desperately need the history from the early history from their parents or somebody. And it's not the case. A lot of time we don't have that information. So I'm having a challenging how to make a accurate diagnosis for the adults who come to our clinic for the first time.
Mm-hmm.
And and I don't know. I don't have any answer. And I hope we will find something like, when, Sandy has an amazing group of patients that the individuals with autism that she has been caring for and studying, and hope that we will do some understanding and study that how the kids with autism were diagnosed in the young age with variety of spectrum look like when they become adult. So then when these adults come in and then say, I think I have autism, and then know that, oh, they look like this when, they were young, and these people look like this at actually at this age. I think that's one way that we can resolve these issues without the developmental history data, but it's a really challenging thing for us to do. Um, Neurodiversity, neuroforming care. I love the idea about this, right. Yes, we should do that. But is this, um, are these people really have autism? That's the question that I'm having. I
Mhm.
have a hard time that
Yeah,
without developmental histories.
yeah, that can get really complicated. And to add further to the adult diagnosis problem is there a lot of the medication, the healthcare reimbursement is based on children. Like there's no reimbursements for diagnosing adults, so it's really hard. People have to, either pay out of pocket or just rely on their own like internet diagnosis, and so that can be really challenging. But I will say to the neuroaffirming care comment that I do think bringing autistic voices into the research is really important, as um, having a voice in what questions that we're asking as researchers. And I think I've seen an increase in that, not only in the United States, but in other countries too, where bringing that voice, really helps to bring out questions that we don't think about, but somebody who's autistic may think of questions that are super important in relationship
Yeah,
to
yeah.
neuroaffirming care. So that's we have some work to do in that area for sure. Um, let's see, here's a question regarding prevalence and incidence. Are co-occurring diagnoses such as with other neurodevelopmental disorders considered as well? And how does that change interpretation, if any?
Yes, we do make a comorbid diagnosis. I haven't looked at for the instance diagnosis, we didn't look at that right now. But so yes, there are a lot of comorbid conditions. I don't remember the specific numbers. I cannot think of, but it was very common to have ADHD, um, especially in the non-clinical population. The scores of the general developmental psychopathology has been so elevated, like ADHD, behavioral problems, mood anxiety. So these kids, these behavioral and emotional problems, like overcasting or overshadowing their other symptom, the ASD related symptoms. So they are often, some of these kids are often misunderstood as um, um, like oppositional defiant or mean or selfish kid because they kind of are rigid on certain things and they don't understand the other person's perspective, yet they look like they're very smart. So, for example, this is the case that we are trying to have a conversation in the ADAS, and I say, hey, I like Chinese food, and our autism kids who's happen to love the special interest is in the food. Like, okay, there are 4 different types of Chinese food, and then give a whole lecture. and,
Mhm.
and can you even imagine how it will go with his or her peers? That they're gonna think, oh, he's like showing off. I don't want to talk to him. He's like, how much he knows and this kind of. And often these kids can have much better relationship with adults because adults get fascinated. Wow, this little kid knows this much about the food. So they are much more scaffolding the kid and supporting and then have kind of conversation on the subject of their special interest. So, but in the peer group, they are having really a lot of difficulties. So yes, it gives me something to do that I have to look into uh, the comorbid conditions in our study that I didn't give a diagnosis. I showed the scores, but I will look into that again, go back and then come back to you and then report it.
Fantastic. Yeah. And I think that's all the questions in the Q&A. I know somebody asked, and Leslie, we might be able to answer about being able to be notified about other lectures on the Autism Consortium. I don't know if they're automatically added to that, or can you?
When I send out the CEUs, which I'll do by next Friday, I always ask if they would like to be included, or if you feel comfortable, you can put your email in the chat now. But I'll definitely ask you when I send the CEUs. Also, after this webinar, you'll be receiving a link to complete a survey. We really value your feedback and really look carefully at those things, so please do complete it.
I just want to answer Gladys Cortez asked that you mentioned play therapy does not work. Can you clarify whether that was specifically addressing autistic behavior or other things? I was specifically addressing to autistic behaviors because the play therapy in Korea was geared for autism symptoms.
Yeah, that's a really good question. I'm glad you caught that one. Because I do see, like, in social work in my field, they use a lot of play therapy, but it's different. I think a lot of autism interventions use play. That's different than play therapy, right? So
Right.
they use play for to promote social communication or reduce challenging behaviors or other things. Whereas play therapy in the mental health field is more about like mental health challenges that kids have, with trauma and things like that, and use play to bring that out. So those are so I don't know if people online are thinking of that.
Yeah. It's a completely
Or not.
different, it's more like psychodynamically,
Yeah.
analytically oriented. Like, no, autism has nothing. Mom did not
Yeah.
do anything bad.
Yeah.
So don't blame mom.
Right. Yeah. So play is definitely used, just not what's called play therapy, I guess.
Right. That's what I meant by that.
Yeah. Yeah, so this has been great, and thank you everybody for attending, and hopefully and we'll see you in the future. And thank you, Dr. Kim. Dr. Kim is going to be working with us on really trying to build up our autism work that we do here in Central Texas. So this is super exciting.
Yeah, I'm so excited, and I'm so lucky to have Sandy and Sandy's group. So thank you for inviting me, and thank you for coming to this. And I am very honored to have all this big, the diverse group from different states. Thank you.
All right. Thank you, everyone.
Bye-bye. Have a wonderful weekend.
Yeah.